Welcome, everyone. We're really glad that you're here with us today. I'm Scott from the Blue Circle Health team. And just really quick, if you're not already familiar, at Blue Circle Health, we support adults with type 1 diabetes through a virtual clinical care, education, and support program. And a big part of that is helping people feel a little more confident, a little more supported, and a little less alone in this. Today, we're talking about something that doesn't always get as much attention as it deserves, the people who live alongside us with diabetes. And when someone has type 1 diabetes, we're usually the ones wearing the devices, taking insulin, and making all the day-to-day decisions, but diabetes often affects the people around us too, spouses, partners, family members, and close friends. And while those support people usually want to help, it isn't always obvious what support should look like. What helps? What doesn't help? How do you support someone without overstepping? And how do those needs change over time? So those are some of the questions we're going to explore together today. I'm especially excited about this conversation because we're bringing together several different perspectives. Joining us is Sherry Roberts, one of the amazing CDCESs here at Blue Circle Health, who's also lived with type 1 diabetes herself for more than 35 years. And Sherry brings her professional expertise, what she hears from the patients she sees, as well as her own lived experience to the conversation. We're also joined by my wife, Tabitha, who has spent many years living alongside me in my type 1 diabetes and has experienced firsthand what it means to support a loved one through the ups and downs that come with it. And between Sherry's clinical and lived experience, Tabitha's caregiver perspective, and my own experience living with diabetes, we're really hoping to have a very honest and practical conversation. But before we get started, I do need to take care of a couple of quick housekeeping notes. So please feel free to use the chat throughout. I'll be keeping an eye on it as we go. A reminder that this session is being recorded. Participation is completely voluntary, and anything you share, like messages in the chat, may be visible to others. And just a quick reminder that we're not providing medical advice or any specific product endorsements here. For anything specific to your situation, we always recommend talking with your healthcare team. So again, our goal today is really to help family members, partners, and support people better understand what life with type 1 diabetes can look like, maybe share some practical ideas, and also to help us, those living with T1D, learn what we can do to help those who want to help us. I also want to point out that this is the first in what we hope will be an ongoing series on this topic. There's just so much to cover and so many situations and perspectives. So if this is something that you'd like to see more of, please do let us know so that we can keep it coming for you. Sherry, Tabitha, thank you so much for both joining us today.
Thank you.
All right, to start, Sherry's going to walk us through some basic information, and then we'll open it up for discussion. So with that, Sherry, I'm going to switch over to your slides, and feel free to take it away.
All right. So I wanted to provide some information that would be really helpful for people to understand, and some of the clinical terms that your person with diabetes might say, and make sure that everyone is kind of on the same page with what some of those words and what some of that terminology means. So we're just going to start with some of our basic terms that you might hear. And we're going to start with the blood sugar terms. So one is called time and range, and that is considered between 70 and 180. So when your blood sugars are between 70 and 180, and we often see that on our continuous glucose monitor, if you're using one of those. So I know that not everyone is using a continuous glucose monitor, and they may not have access to that. But there are some ways that you can find what your time and range is outside of using a continuous glucose monitor, and we can definitely address that if anyone has that question specific. But what that really means is blood sugars between 70 and 180. And it's also really important to know that what these ranges are set at are the clinical ranges that the standards of care by the American Diabetes Association has set forth, and that some people may have different time and range goals or parameters set by their provider, depending on where they're at in their journey with diabetes. So I just want to kind of make sure I make that clear. But then you might hear the term hyperglycemia or high blood sugar. And that is typically meaning that a blood sugar is higher than 180. And some people may experience blood sugars much higher than that. And sometimes they'll have signs or symptoms when their blood sugars are higher than that. And sometimes when somebody is, in that 180 range, that is too high for them and what their target is. So again, it's very specific, but this is what it means when you hear the word hyperglycemia or high blood sugar. And then moving on to hypoglycemia or low blood sugar. And this one is when your blood sugar is less than 70. So again, that's the clinical definition of what hypoglycemia is, or low blood sugar is when your blood sugars are less than 70. And sometimes people might feel low blood sugar symptoms when they're when they're higher than that. Again, depending on where they've come from, what their targets are, kind of their age. So again, those numbers can all be different for people. But again, the definition that's been set forth, low blood sugar or hypoglycemia, is blood sugars less than 70. Okay. And then we might hear the term A1C. So A1C is a measurement of the average blood sugar over 3 months of time. And that is one that many people, myself included, dread to get that reading every couple of months. You might be nervous about going to your endo. You might be nervous about going to your doctor, wondering what that's going to be, being judged if it's not where it needs to be. But it's really, it's a data point. So again, it's the average of what our blood sugar is over 3 months of time. And so again, I just wanted to kind of make sure that you guys were aware of what that means. And it's important to remember, again, that people with diabetes may feel comfortable at different levels and have different blood sugar goals than the person next to them that has diabetes. Okay. All right. So I wanted to make sure we covered those terms so you can have information about that. And then another set of common terms, again, is CGM or finger sticks. CGM is that continuous glucose monitor that people will wear, like a Dexcom or a Libre or Eversense. Those are the big ones on the market right now. And they tell you what the blood sugar is without having to do a finger stick. And finger stick is where you're using a device. It's called a lancet. And you're pricking your finger to get a drop of blood, and then you're putting that onto a strip, which slides into a small device, and that will tell you what your blood sugar is. For those of us with diabetes for a long time, that's what we used to use all the time to check our blood sugar. There was no continuous glucose monitor, but now we have those available for us. Okay. Then we have the terms insulin pump or multiple daily injections. And those terms refer to how insulin is delivered. Okay, so again, some people might use an insulin pump and some people might use injections, multiple daily injections, because they have to do it many times throughout the day. And so again, that's how insulin is delivered. Okay. And then another term that is important to know for people with diabetes and their family members is carbohydrates. You might hear that term a lot as feeling that you need to restrict your carbohydrates. That's often a term that's or a phrase that's used, but carbohydrates are foods that break down into sugar. Now, it's important to know that people with diabetes, type 1 diabetes especially, we do not have to restrict our carbohydrates. It's really important to take your insulin for the amount of carbohydrates that you're eating, but there doesn't have to necessarily be a restriction of carbohydrates. Okay. And then lastly, for our common terms that I'm going to refer to today is diabetes distress. So diabetes distress is a term used to describe the mental and emotional load of diabetes. As many of you know, you don't get a day off from diabetes. It's 24/7. And sometimes it can lead to distress, and that's okay to recognize that, and it's okay to be experiencing that. It's very normal for people with diabetes to experience diabetes distress. All right, let's go to our next one. Okay, so this is where we're going to have a little bit more discussion with Scott and Tabitha. We can kind of open this up about any comments about those phrases, those terms that I've already gone over.
One of the things that I'd like to make mention of, especially thinking about the like the low blood sugar thresholds, right? So, for example, I do still feel my lows, and it usually is right around 70, but it can be different depending on if I'm maybe dropping fast or something like that. So if I'm dropping quickly, I might start feeling symptoms of a low blood sugar even before I hit that actual threshold of 70 in terms of my blood sugar. And I think that's a pretty common thing. Sherry, do you ever experience that?
Yes, definitely. I will feel it if it's dropping faster. And it can kind of happen all of a sudden. And my kids used to say to me, danger zone, when they could tell that my blood sugar was dropping.
Yeah, it's something where, learning kind of where and when to start asking questions can be a big point of contention. I feel, honey, like we've got a pretty good balance there. We do have a sugar pixel device that's up in the bedroom. So Tabitha can see that while we're there together and while I'm sleeping, but also it helps her keep an eye on things when I'm traveling. And I don't have to travel as much as I used to anymore, but I would like to think that provides a little bit of peace of mind. But Tabitha, do you want to talk a little bit about what that means for you to be able to kind of see blood sugars?
Yeah, I help when you have that in front of you. You can't always tell when you're having it low when you're with me, but when you're high, you're really tired, and I say, you're really high, and you usually know that. But when you're away from me, I have no idea. So having that in front of me has been awesome, especially when it's in the middle of the night, because that's when I worry the most. I know you're super busy with meetings and stuff late into the night. And so I'm always checking that because I haven't heard from you. You always call me before you go. I haven't heard from you. I'm checking that to make sure you're okay. And it's weird that when you do have lows, which is not that often when you're traveling, you magically wake up and my eyes go right to that. And I start calling you nonstop, calling and texting nonstop.
Yeah, and it's interesting because we use that sugar pixel device, but we haven't made use of like the Dexcom Share feature that's a feature for Dexcom, and I believe Libre has a similar feature where we could set it up so that Tabitha could see my blood sugars anytime and also be alerted. We actually haven't done that, but using that sugar pixel is a good option, a good easy option. So another thing that's kind of cute. So we have a 9-year-old granddaughter that lives with us too, and one day I was off at a meeting or something. I wasn't home, and I get a text message from her asking about my blood sugar because she's learned what it means. The certain numbers they're color coded and things like that. So she was thinking about me as well.
That's really funny. I also have a sugar pixel, and my daughter made the joke. Same daughter, talking about how she can tell what kind of mood she's going to be in. I'm a high or
Yeah, I'm sure that
So it's good.
I get cranky and like you described, Tab, tired when I get high, things like that. So it's it certainly does affect things. Tab, I want to ask about what is something that maybe surprised you the most. So just for a little bit of background, Tabitha and I have been together for a very long time, since high school. We started dating in like 10th grade. And so, but I was diagnosed with my diabetes at the age of 5. And so it's really, diabetes has been a part of the picture for as long as we've been together. Is there anything that surprised you, if you can remember that far back when we first started dating and talking?
I think how well you managed, because we were very young. He probably had it maybe 11, 12 years then. Like we were still very young, but you managed this. So, but it was new to me, so I felt like I had to mother you. And there were times when you almost would bat my hands away. Like, I got this. Okay, I don't really need you to. So I figured out when you wanted me to kind of help you out, or when you kind of had it under control.
And do you feel like that's changed over the years?
Not really. No, you still manage very well, and you do not baby. So, so I baby the baby because you got yourself under control.
Yeah, most of the time I feel like I feel like I do pretty good, and there's also an element of diabetes can feel sometimes chaotic in my mind, and I think I'm sometimes guilty of trying to shield you from that chaos so that you don't worry, or you're not kind of burdened by some of the same things that are burdening me, because it's raising a household and working and living life. It's busy, and I don't want you to feel unnecessarily worried about things that are going on. Sherry, what does it look like in your household?
Oh, well, that's a good question. No, I'm just kidding. No, I have a really good support system. My husband can look at my eyes and tell me if I'm high or low, which is pretty amazing. And he has done quite a few things to help me over the years. But I think one of the things that's been really good is talking about situations before they happen.
Yeah.
So, like, practice how to treat a low, practice where my best, like glucagon is at, and communicating what I want him to do if he sees a low on his next nap. So that has been a big help to have those conversations before we get to those situations, to kind of know what to expect and how he'll help me and how in different situations.
Yeah, I think that's really smart. And I admit it's not really something that we've talked about, but when I'm having a low blood sugar, I'm feeling low, right? And so sometimes there can be a little bit of kind of just my brain slows down a bit, right? We don't have the fuel we need to think clearly always. But in addition to that, my phone is beeping at me and going off, and my watch is beeping at me and going off. And if you have a connected insulin pump, that's also beeping and going off. And so it can sometimes feel a little bit overwhelming when there's all this stuff happening, you're feeling low. And I think Tab has done such a good job of kind of recognizing, especially if we're together, if I'm there, of what could be helpful versus not. That's of course a little bit harder for you to see when we're apart or we're traveling. But I think you've landed in a really good place where, you'll watch it for a while, and if I start coming up in 10 or 15 minutes, then, you kind of leave it alone. But if I stay low and continue to stay low for 10, 15 minutes or so, which is usually about how long it takes for the treatment to work anyways, then you'll start checking in. But I feel like you've developed a good balance in that. Is that something that was surprising for you to learn too as well? Like just how long it can take for me to fix a low. Even if I eat something right away, it takes a while before it shows up on our devices or CGMs.
I think in the beginning it surprised me, yeah. But obviously now I do understand that. It was funny, I was speaking with somebody today at work who's also a type 1 diabetic. And I talked to her about when you travel and how I kind of panic if you get low at night. And when he finally called me back, he said, "Buddy, I was treating it. That's why I wasn't able to get back to you." And she just said, when you have a low like that, she said, that's all you can think about. It's not really thinking at all. She said, my brain is very much, I don't really remember a whole lot depending on how low I went. And she said, he's probably just taking care of himself. And then as soon as he's feeling better, he will get back to you. I said, I have to remember that because I can only imagine how not so good he's feeling. And she said, yes, it's not a good feeling when you get really low.
Yeah, it's wise words. But that's hard though, because you also worry. And I can appreciate that when you see something happening with a loved one. We've got a really good question in the chat. And she asks, how does that feeling of knowing that I'm shielding the full impact of my diabetes affect you, Tabitha? She shares that her husband tends to get frustrated with her when she shields it. Do you wish I would let you in on more of that stuff?
I do. I don't want you to take it on yourself. I think you used to share a little bit more when we first started dating. I'm such a chaotic person myself. I probably never tend to help much. But yeah, I would love to be able to help you and support you in some of those things. You don't have to take it all on by yourself. And I know that our lives can be chaotic, but any way that I can help, I'm happy to. And I'll try to remain calm.
Yeah,
I know I'm very hectic, but I can be calm sometimes.
It's a great mix. Your hectic and chaoticness is part of what I love about you. I do think that there's also it's interesting to hear you say that I maybe am sharing less more these days. I feel like I'm in a place where it's not occupying as much mental and emotional space as it used to. I'm on a, what feels like a really good puzzle mix of medications and technologies where I feel like I'm achieving better results than I have in years and decades past, and also working less hard. And so that might be an aspect of it too that you're seeing.
Well, and that's how it presents. So that's great.
Yeah. Well, we're going to get into a little bit more about some of the tactical aspects of it, but some of the important things that we wanted to get forward in this first little chunk here was the importance of asking questions instead of assuming, right? So sometimes that can be the most helpful thing, is asking questions. What would be most helpful right now? What are you feeling? And there's a lot of times where I don't want to think about diabetes at all, and that can come through as well. I think there's also the element of recognizing, supporting, and influencing our diabetes management versus, there's this want to apply some levels of control to diabetes, and that's a taboo word for many of us living with diabetes, because even as well as we know our diabetes and our medications and devices, sometimes the best we can do is influence our diabetes, right? There's also the aspect of the diabetes police, right? Checking in on, should you be eating that, or is that really the best decision right now? Sherry, do you hear any of these things come up in either your life with diabetes or in some of the patients that you serve here?
Yeah, I hear that a lot, especially about food, like being told they're not allowed to eat something or they're not allowed to enjoy something because it has sugar in it. So we spend a lot of time about kind of discussing where that fear is coming from the support person's point of view, and offering ways to provide tips and stuff to give them education about that as well.
It's interesting you mentioned that. Sometimes especially around the food, like there's sometimes where I just need to have a sweet treat in the evenings when I'm watching movies, and I take my insulin, and we know that my blood sugar is going to go high for a little while, and it'll come back down. But it's sometimes we need those treats for our emotional health too.
Yeah, for sure. So it's just like one of those conversations that you have to try and get the picture made and, let people know that it's okay to have those things. And when they're not being policed, that's the best time to have that conversation. So it's not in the heat of the moment.
Yeah, that's a great point. I think it's also important to recognize that, again, support needs can change over time as things with our diabetes evolve, or maybe insurance changes or things like that can really affect what our support needs are at the time. And also, I think our relationships themselves evolve and change over time. Tabitha and I are enjoying growing up into our grandparent age together, and that looks a lot different than it did in our teenage and young adult ages. Sherry, has your experience with your family and through raising kids and everything, have your support needs changed and the relationships changed?
Oh, for sure. Definitely. I think now I'm better about advocating for what I need. Whereas before I would just like go and not stop, even if my blood sugar was low or high. And of course that wasn't always the best thing, but now I'm able to do a better job at recognizing and telling people what my needs are.
Yeah. Can you share any examples of what it looks like to advocate for yourself?
Yeah, so I asked my husband to help with insurance stuff. Like the idea of calling the insurance companies when there's any type of dispute or something, it just causes me a lot of stress. So he has offered to take that off my plate. So he makes those calls, and he advocates for what my needs are as far as coverage goes. And that's been really helpful. And another thing that he does, and he did it just last night, and it made me really happy, is if we have pasta, he will not mix the sauce and the pasta together, which seems so silly, but he knows that I don't like a lot of pasta, but I like sauce. So he separates the two and then lets me get my pasta and my sauce. And then, it's just a really simple way to offer me support.
That's really sweet. And that's something that Tabitha does at our house a lot too, because I eat more like a child than a mature adult. And so sometimes I don't like the dishes that has all the stuff mixed in it together. So she'll kind of ask me as she's preparing what components I want and set those aside. That's a great example.
Yeah, he's been a big support. And one funny thing I have to say is, like, if I get frustrated about my blood sugar being high, he will say, well, it's just me. I'm made of sugar and you're right next to me. So it's just making you go high. So he's always trying to make a joke to make me feel better. But I'm like, yeah, if it was only that easy.
I love that.
Yeah, I'm going to steal that one.
Yeah, that's a good one. Another great comment in the chat that mentioned saving the boxes of foods or ingredients so that it's easy for us to check carb counts. I know sometimes Tabitha is taking pictures of something before tossing it in the in the trash can. So, that's great. Sherry, as both someone living with type 1 diabetes and a clinician, how do you explain the mental load of diabetes? And you talked a little bit about diabetes distress. Can you dig into that a little bit more and explain kind of what that looks like and how it's made up? And I'm not expecting you to go through all of the different subscales. I mean, I wouldn't be able to remember those without looking at a reference, but maybe just some examples of what kind of things can all add up to equal diabetes distress for us.
Yeah, so when we have that fear of highs or lows, that can be a big distressor. Financial fears or financial concerns covering diabetes, feeling like we're a burden to others, not feeling comfortable with our management or our healthcare in general. Those are some of the big ones. Technology concerns can be a distressor. So those are probably some of the most common ones that I see and talk about a lot with patients.
Yeah, and one of the, let's take, for example, a fear of low blood sugars, right? That can cause someone to intentionally run higher than ideal for them. But again, it's very individual. And so I think it comes back to that point about asking questions versus assuming, right? So just because my ideal target that I'm shooting for might be 100, that doesn't mean that your target, Sherry, is the same, especially if you're dealing with fears of low blood sugars or another thing that can sometimes happen with us, especially those of us who have lived with diabetes for a long time, is something called hypoglycemic unawareness, which means we don't always feel our low blood sugars at the same numbers. And so that can lead to very intentionally running a bit higher to give a little more cushion for avoiding those low blood sugars. Does anything else come to mind as I talk about that?
Oh, yeah. I mean, I think that's really important to address and recognize, like where I say, okay, this is a clinically 180 is high, but someone else may feel low at 180 because they've run high for so long. Their body's not used to being in range. So it takes time to get used to being at that 180 range. And so it's important if you have somebody following you or tracking you, and you have that conversation, be like, this is where I'm comfortable at right now. And I'm going to work on it, or I'm going to stay here. But having those conversations to recognize that everyone's different in that situation where they're low.
Yeah, that's great. Can you also, Sherry, talk a little bit about what caregivers maybe often misunderstand about diabetes burnout or decision fatigue? That's a big one in my household, is that decision fatigue. We'll come back to that in a second.
Yes, decision fatigue. When someone is living with diabetes, they are making a decision about how much insulin to take for food, for coffee, for exercise, for stressful moments. So they're constantly having to make a decision about things. I think it's been recorded that we make over 180 extra decisions a day, which just gets to be exhausting. And so sometimes if you have I have a support person that's willing to make some of those extra decisions, would be really nice. Like, what movie are we going to see? And okay, you can pick this time, and that's okay because I just don't want to make that decision.
Yeah, that's one I can relate to that big time. And Tabitha, I'll ask you about this in a second, but oftentimes we're trying to figure out maybe what do we want to do over the weekend, or what do we want to watch, or where do we want to go and eat? And especially if it's kind of late in my day, like I don't care. I just don't want to have to decide about anything else. And like, just tell me where we're going. I'll drive us, like whatever. I just take that decision off my mind. But Tab, when you hear us talk about that, does that resonate with you? It's something I know I've experienced from my side, but what does that look like from your perspective?
Well, when it comes to asking you what you want to eat, or if you want me to make you a little extra, scooping it, making something for a little extra, when you think you're responding that way, I'm okay with that. When I ask you, do you want to watch a movie tonight? And you take 5 minutes to answer, I do. I'm like, well, I don't know if I'm going to go take a walk, and maybe when I come back, you'll be able to answer. I have to remember though, because you've told me that before. I don't want to decide anything else. So I just have to try to remember that and try to not get so, I get kind of impatient with that. So I have to remember he just doesn't want to have to decide anything else. I can pick. It's fine.
Yeah, it's and Tabitha's mind moves very fast. She's a fast, brilliant human being who thinks fast, and sometimes she'll ask me a question, and it's almost like she can see the spinning wheel on the computer. I'm processing, and then when I answer the question, I'm over explaining everything about what my thought process was, and she's just like, "Oh my, would you just answer the question?" And it's hard to remember that it's often with diabetes, there is no just answer the question, because everything we think about involves these multi-step processes. So I love that, I love that we both recognize it. I can see how in some relationships it could become like a pretty big point of contention. But I think we do pretty well with it, and we have our ways, right?
Yeah, now we just need to teach our daughter to be a little more patient when she asks you a question.
Yeah, she is much like you. So, when you, Sherry, are talking with some of the people that you serve clinically, and this is coming back to another great question in the chat, how does everyone else help their people not be judgmental about the struggles that we all have with our diabetes without alienating their loved ones? Do you have any thoughts there on either from your personal perspective or from those that you serve clinically?
That's a good question. I feel like it comes back and back and back to communication. Letting them know that you're not doing this on purpose. You're not having a low to get out of something. You're not having a high because you're trying to avoid something else, So I think that it's so good to have these conversations before we get to that point. There's resources out there that have humor to kind of help with some destigmatizing. Diatribe, I think, is the one that I'm thinking about, has Spoonful of Laughter, I think is what it is. But yeah, some really funny videos that you can share with family and friends that uses humor to try and remove some of the stigmatization.
Yeah, that's a great resource, and I'll be sure to provide a link. And you're right on. It's Spoonful of Laughter, which is a campaign and program from the Diatribe organization. So they're great. Honey, how has that been with you in terms of kind of trying to figure out how to help me without being judgmental about maybe the decisions that I'm making? Or, we talked earlier about sometimes I just need to have that, bag of jelly beans or whatever it is for my emotional health, knowing that my blood sugar is going to take a hit for a little while. And I could see how that could be very hard to understand and know, especially from the outside looking in. What's that experience been like for you?
I don't know that that's ever something I'm judged you for. I just know that how difficult it must be to try to manage. And I always think if I were type 1 diabetic, how would I handle it? I don't know that I would handle it very well. So I admire how well you handle it. So I just don't feel like when you need a sweet treat or something for because you're having an emotional day or just because you want to have some M&Ms with a movie, I don't judge you. I understand that that's something that you might want. I also understand that you manage your diabetes very well. And again, I look at myself and I say, gosh, I just don't know if I would manage as well as he does. So I'm just there to support you and share some M&Ms, hopefully.
Yeah, of course. Well, and you're a very empathetic person to begin with, and I think that makes it easy. It makes it easy for me to feel supported and cared for in our relationship. I do think it also probably makes you worry and feel some of the hard days that I have more than usual, I think, too. So that's great. Go ahead, Sherry.
I was going to say one other thing that I like to tell people, that I can eat anything as long as it doesn't have poison.
Yeah, that's a good line.
If it's cookies, as long as the cookies don't have poison, I'm good to go. So I try again to keep with humor sometimes, and just it doesn't have poison, I'm good to go.
Yeah, there's another.
And that's funny because one of the things that bothered me most is when we were first married and we'd go to events together, a lot of people would see him eating something sweet and they say, "Oh my goodness, you can't eat that, can you?" And I couldn't. It just drove me insane. I wanted to walk away, but I told him, I said, "Honey, from here on out, if anybody says that to you, I'm going to run up to you and smack it out of your hand and say, 'Oh, you're right. Thank you. Thank you for helping us with this.'"
Yeah,
we know how they would react. But I haven't had the chance.
Yeah, that would be a funny moment. Yeah, we'll have to stage an uprising or something here. That'd be funny. There's another great comment in the chat that talks about how, especially those of us who were diagnosed as children, we worked really hard to show and kind of prove our independence in managing our diabetes, and that I think is something that it's a tricky balance, especially as we're kind of coming out from under the care of our parents and starting to navigate the world alone. We had to work really hard to prove our independence. And I think some of us have carried that on like a little bit too far and too hard, right? So it makes me think about talking about how I often shelter Tabitha from as much of my diabetes as I can, and probably too much. And maybe that's a kind of a side effect of this need to prove my independence as I was growing up. Any thoughts around that side of things, Sherry, and perhaps what we can try and remember in our minds as we're, because we are independent, and but sometimes it's nice to have some help too.
I think that for myself, it goes back to that judgment from years and years and years ago, right? Like I wouldn't want to share or let anyone in because I thought I was going to be judged.
Yeah.
And it even was that way when I first started with Dexcom. I wouldn't share my data because I didn't want to help. I was like, it's a tattletale. It's going to judge me for this and that. And so it took a lot of just reframing my thoughts when I was finally told that the numbers don't judge me and my self-worth is not defined by what my numbers are. And once I was able to do that, I was able to start letting people in slowly and find other ways to ask for help as I got more comfortable with sharing information.
Yeah, I can see though how it's very it's easy to feel kind of too proud to ask for help. I would love to hear from those of you watching if you've ever heard the phrase, like if someone is shared their numbers with you and it's not in target, right? If it's high or low, if they would say like, "Oh my gosh, what did you do?" or "What happened?" implying some almost some blame, right? Like that's never how it's intended as that person is asking that question. But let me know in the chat if that comes out. And Sherry, I don't know, do you hear about any of that while you're with the patients that you're treating?
Yeah, I hear people say that a lot. They'll have family members that want them to treat the low over and over and over again because they're afraid for them. And so they are not able to just stop with the low treatments. Their family member wants them to keep treating. So we talk about ways to try and talk about that and work through that together.
Can you talk a little bit about, I believe you had another couple of slides that were like the common symptoms of highs and lows. I'm going to bring you back on screen with us and your slides. Let's talk through some of these, as I think that's a great, I want to make sure we get this information out there too.
Yeah, so this is a big point. I think we want to make sure family members and our support people know that when we're treating high blood sugars, we need insulin. That's not when we need more food or more sugar. That's when you might need insulin, is to help treat a high. And high blood sugars that are left untreated can lead to DKA, which stands for diabetic ketoacidosis. That is what DKA stands for. And this has a lot to do with missing insulin doses. So not just high blood sugars, but missing insulin doses is really important to know that leads to DKA. But some of those, the signs and symptoms with DKA are going to be like the nausea and the vomiting. That's probably the most common. Headaches. You might have some abdominal pain, a fruity breath smell, rapid, deep breathing. Again, you might have the extreme thirst and frequent urination, but the nausea and vomiting is probably the really big one because you can get really, really dehydrated when you have DKA. And when you get dehydrated, your insulin isn't working as well. And so then you're going to have more trouble bringing the blood sugar down. So if you ever start to experience the nausea and vomiting and you're having high blood sugars or you're having ketones, if you check for ketones by peeing on a strip or using a meter to check those, and you have those and those symptoms, that's when you would want to go to the emergency room for care. And so I always like to tell people too, if they go to the emergency room because they're feeling like they're having high blood sugars, I would say when you get there, tell them you have type 1 diabetes, you're having nausea and vomiting, and your blood sugar is high, and you're worried that you might be in DKA. And that should hopefully light a fire under their, with the admin people, so you can get seen rather quickly, because it can be really dangerous and it doesn't take long for people to get into serious, a serious place.
Yeah, and that's something that we've, I have gone into DKA maybe 2 or 3 times in my adult life with diabetes, and it's usually due to a pump site malfunction or something like that. And yeah, you're right. And those are times when we definitely need help. I need a ride to the urgent care emergency room so that I can get some help with that. Okay, and do we have another one for low blood sugars? Let's talk about that too.
Lows. Yep. So when we have lows, that's when we need to treat with sugar. So that's when you don't want to take extra insulin. It's again when you treat with fast-acting sugar. Things like Skittles, juice, glucose tablets, those are the things that are going to have that fast-acting sugar. If we use things like chocolate or cookies, all great things to have and enjoy, but those are not going to bring your blood sugar up as quickly as you need for them to, because they have fat and protein in them, and that fat and protein can slow down how fast sugar works. So you typically want to take in about 15 grams of carbs or less, depending on if you're on an automated insulin delivery system. You may not need quite up to 15 grams of carbs, but it's important to know that's a good starting point. And then you wait 15 minutes, and then you can recheck your blood sugar and treat again. So it takes a little bit of time for the sugar to work. But when we use that fast acting sugar, that's going to help you come up faster. And then you won't feel as poorly for as long. And then you can hopefully prevent a rebound high that tends to happen if we overtreat those lows. And then one more thing before I talk about the symptoms of those hypoglycemia, but it's important to know that it can take time to recover. Just because the blood sugar has come up to a normal range doesn't mean that we are able to make solid decisions about, important things. Sometimes it takes a little bit of time for our brains to recover from those, from low blood sugars. So
I think that's a really great point. I'm so glad that you mentioned that, because that, especially I feel as I age with diabetes, the lows and the highs, they take it out of me a little bit more than maybe they used to. And I appreciate that Tabitha has, like, our relationship with my diabetes has evolved to a place where if she's watched me have a tough blood sugar day with highs or lows, or even if I maybe have been in good range all day, but it's like it's taking everything I've got to stay there, she kind of recognizes that I might be feeling a little bit more tired, or my fuse might be a little shorter that day, things like that. And again, I think that's something we've never really talked about that. I think that's something that, again, with her empathetic personality and gifts, she's just picked up on. But I love that you talked about how it can take so much time to recover.
And I think it's important to know, too, that the signs can change over time. Like sweaty, like cold sweats are kind of the typical one, shakiness and things like that. But after you've had diabetes for a while, like Scott mentioned before, you might start to have hypo-unawareness, and the signs can change. So like nowadays, I don't necessarily have those cold sweats or shakiness anymore. More of it now is just kind of feeling dazed. Like I will keep repeating myself over and over again. Like I can't come up with a clear thought. And so I know that 2 + 2 is 4, but I couldn't tell you that 2 + 2 was 4. So things like that happen. Tingling of my tongue, tingling of my lips, some of those might happen. But again, the signs and symptoms can change over time. And again, it's important to try and ask. And then, another shout out to my husband. He can tell by looking at my eyes whether I'm high or low, mostly low. And of course, he would say, this was before CGM, you need to check your blood sugar. And I would be like, no, I don't. And he would be like, yes, you do. And like almost 100% of the time, he was right. But I just didn't know, I didn't feel the lows anymore and that sort of stuff. So, but yeah, it's just, it can take some time to recover and to now identify always what's going on.
I think it's important also to recognize that the symptoms of lows can be different from low to low. And so yes. I don't always feel the same symptoms, and they can be different from low to low too. So I want to share a couple of comments in the chat. One mentioning, when I asked about the question of, what did you do, or why is your number like that? Just feeling, hearing that often from older family members and feeling almost like a little kid in trouble. I think that's something that we can all relate to. And then another comment about being hypoglycemic unaware, so not feeling low blood sugars at a usual point, that she tends to treat more frequently because of the worry, and that her body doesn't recover as quickly as it used to. She also shares that her husband can tell when she turns white and will argue with him a little more than usual. That's something I think I'm guilty as charged with that too.
Yeah. And sometimes I tell my husband I feel like I've been hit by a truck.
Mm-hmm. Yeah.
Not that I've ever been hit by a truck, but it just seems like that's what it would feel like, just like smacked and knocked down.
Yeah, absolutely. Tab, can we talk a little bit about, I have had, I think only twice in the past 30 years or so, had a severe low blood sugar that I needed help with. One of the times was overnight when you were home with us and our first son was very young, but another was after basketball. And, I got delivered back home from some of my friends after an ambulance had come. Can you tell me a little bit about how that felt to you in terms of your confidence of me just navigating my everyday life for the next, I don't know, a few weeks or months, or what did that do to you from that side of things?
Well, I know the first time it happened, Bryce was a new baby, and that was really scary for me. I remember calling the ambulance and they calling your parents, scared them half to death.
And your parents too. It was in the middle of the night, and all of a sudden we had the ambulance and both sets of parents there. Which I was so embarrassed, but silly of me to feel embarrassed because, and
I thought so too. We were all very worried about you, but it made me. I was, a little weary, especially at night, and I clearly I still am. Because of that. And I do believe the second time I was actually pregnant. And I remember being really, really calm because you were really calm. And then when we were sitting at the hospital, I remember thinking, this is actually very, very serious. And I'm not as calm as I am pretending to be. And I really freaked out. But you didn't know. It was a very scary time because I just really started thinking, this is really terrible how sick he is right now. I could lose my husband, and I'm trying to pretend like I'm calm, but I'm really, really, really sad and very scared.
Yeah.
So I was really glad when I was able to take you out of the hospital. But it's so funny. My memory is terrible, but I remember those things very well.
Well, they're big, scary events, and so I'm sorry you have to remember them, and that you had to experience them with me. But yeah, and it's I think you also kept your calm because that freaking out wouldn't have added anything. It would have made an already hard situation even harder. So I specifically remember after the second severe low blood sugar that the next A1C check that I had was the highest that it had been in decades, and it was because again I was afraid of getting hit from a low like that. But over time, we were able to get more comfortable, and I was able to get things back down. We've only got a few minutes left here. Sherry, if you might try and sum things up into a single support strategy, and I have a feeling I know what it'll be, and it's probably gonna surround communicating before the need arises, right? But take a couple minutes to talk us through some final thoughts there.
Yeah, I think it's just really important, like I said, and like you said, to talk about it and be willing to be vulnerable on both sides, because sometimes the support person is afraid but doesn't know how to say that. And may then just seem dismissive, right? But really, they're just afraid, they don't know how to help. And then us living with diabetes, let them know where you're coming from and how you can be helped.
Yeah. Do you have any thoughts on? There's a great comment and a great point that we haven't addressed yet. But often, many of us have young children in the home, and they worry about us too. Sometimes, maybe even more than our older and adult housemates. Any thoughts on addressing some of our diabetes to our children and small kids in a way that helps them sort of realize the severity of it at times, but also doesn't cause them unneeded anxiety?
There's a book called Mommy Beeps, and it talks about like devices making noise And it's very simple for children to kind of have that conversation about why you might need juice boxes, or like, this is just my mom and what she needs.
Yep.
So that would be one resource I could think of that might be helpful for young kids. But that's one. And then just again, telling, like, for my kids, they all knew that was my juice box. And so we talked about it, like, why does mommy need that juice box? Where is mommy's juice box at? And so that was what we did. Again, was just we just talked about it. Again, very much at what their levels were, but it was like, this is mommy's medicine. This is what I need to do to stay healthy. I didn't use words like, if I don't take this, I will die. It would be like, this is what mommy needs to stay healthy, that type of stuff.
Yeah, I think that's a great approach. Thank you for that. Any other final thoughts from your side, Sherry, that you want to wrap up with?
Well, I just hope that we can help people feel comfortable talking about this with their families and sharing ways to support one another. Having different terms, I think, because there's such a lingo with diabetes, and sharing that lingo with our family so they know what we're talking about. And that's probably where I would sum things up.
Yeah, that's great. And we'll, again, this is the first of what we hope to be a series. There's so much to cover here. So I recognize how challenging it can be for me to ask you, like, hey, sum it up and wrap it up in a sentence. Tabitha, how about you? I'm going to ask you two questions to wrap things up. What's one thing you wish I would do to make your life as a loving caregiver easier? And then the second part is, what's one thing you wish other caregivers out there in your position knew about their loved one with T1D?
I don't want you to do anything to make my life easier. I think you do that already. Like I said, you seem to have a really good handle on everything. And I hope that if you are not having a good handle on things, you will let me know. And I think you definitely try to understand where the person with diabetes is coming from. Like I said, I think about myself as a type of diabetic all the time, because I see what you have to deal with, and I just think, I don't know how well I would do. I know it sounds terrible to say that. I just don't know that I would be strong enough to do it. So I think that we need to have, if we don't have grace and patience, I think we definitely need to have it. There are, maybe times when your loved one kind of gets frustrated and they get a little snippy, but you have to remember they might not be feeling that well at that moment, and just give it some time. If they're like that every day, all the time, there might be a little something else going on. I don't know how to help you with that one. But just say, give a little grace and a lot of patience.
Yeah, well, you're a big teacher. Yeah, you've influenced me in the grace and patience in many ways, so I appreciate that. And I also think that your colleague with type 1 feels much more at peace knowing that she has kind of someone who understands nearby as well. So that's great as well. All right. Well,
I feel the same about her.
Yeah. Right. Yeah. Absolutely. Well, as we wrap up, one of the themes that really kept coming up tonight is that there's no one right way to support someone living with type 1 diabetes. Every person is different. Every relationship is different, and our diabetes is different from day to day and moment to moment. So what feels helpful today might be different from what feels helpful 6 months from now. And I think what seems to matter most is really that communication, being open about it, and continuing to ask, how can I support you right now? And from my side, how can I help you support me right now? So Sherry, Tabitha, thank you so much for both sharing your time, experience, and perspectives with us today. This was a really wonderful conversation. A big thank you to everyone out there who joined us. We know that supporting type 1 diabetes can sometimes feel pretty complicated, And we hope that tonight we're able to kind of scratch the surface and help make it feel a little less mysterious and maybe a little bit more manageable. So, again, we'll do more of these, looking at more diabetes terminology, maybe some myths, some emergency preparations, technology, and some other practical skills that can help those around us feel a little bit more confident. And then always remember to visit bluecirclehealth.org/events to stay up to date on our upcoming Blue Circle Health webinars and community events like these. And then if you enjoy these kind of conversations, also be sure to check out the Blue Circle Health podcast for additional stories and perspectives from across the diabetes community. So thanks again for spending time with us, and I hope to see you again soon.
Safe gift.
Thank you.